The first symptoms that many vulnerable women experience: brain fog, anxiety, as well as rage. So these sorts of symptoms are brain symptoms, and they start in the mid-40s and they fluctuate.
Welcome to Thriving in Menopause, brought to you by Prevention Magazine. I'm Zoe Mernier, the editor of Prevention. Thank you for joining me for episode 6 of season 10. Today on the podcast, we'll be talking about the serious but incredibly important topic of mental ill health during menopause. This is such a crucial conversation to have and to get right, so I'm very honoured to be joined by someone who is incredibly highly esteemed in this field. Professor Jayashri Kulkarni AM is a psychiatrist and researcher at Monash University who is internationally acknowledged as a leader and expert in the field of women's mental health, in particular for her innovative work on reproductive hormones and mental illness. She'll be guiding us through a subject that can be a real minefield and about which there is a lot of misinformation, misdiagnosis and incorrect treatment. Professor Kulkarni, thanks so much for joining us today.
Thank you, Zoe. It's a pleasure to be with you and your listeners.
Okay, so let's start by saying that people often think of our sex hormones as relating primarily to reproductive health and or changes to our bodies at this time of our lives. But can you talk us through how they actually affect the way our brains function?
Yes, so the sex hormones we're actually referring to are estrogen, progesterone, testosterone, and their precursors. That's luteinizing hormone, follicle-stimulating hormone, DHEA, and then their precursors. So when we look at all of that, 2/3 of that is all in the brain. Estrogen is produced by the ovaries, as is testosterone and progesterone. However, it is all controlled by that master controller, the brain. So what we have somehow managed to forget about is, or not know about enough, is that the hormones, estrogen and progesterone and testosterone and their precursors, are all really, really potent brain steroids. And that means that they actually impact and can control brain chemistry. Now, we all know about serotonin and these chemicals that are related to mood, and it's actually not well known, but estrogen is a potent mood controller through serotonin. So when we look at a big hormone fluctuating event like menopause, which, by the way, starts in the early 40s, and is about an 8 to 10 year process, it actually begins in the brain because these hormones start to fluctuate in the brain. And the first symptoms that many vulnerable women experience, not everybody's going to experience mental health issues, but the vulnerable women, we don't know what makes some women more sensitive to their brain hormones than others, but that's what I mean by vulnerability. They're sensitive to brain fluctuations in hormones. These women in their 40s are going to start the menopause process with brain fog, which is that sense of I can't think through things, even though I've done this a million times before. I'm just not sure how to turn on my computer or work this program or whatever. Brain fog, anxiety, sudden panic and anxiety about things that she's done before. I know I've given this talk a million times before, but suddenly my heart's racing and I've got a dry mouth and I don't think I can do it, as well as rage as one of the early depressive symptoms, and that sort of overwhelming rage about not much that's gone wrong. So these sorts of symptoms are brain symptoms, and they start in the mid-40s and they fluctuate. So sometimes women get these things and then it goes on for about 2 or 3 weeks and everyone's looking at her like, what is wrong with you? This isn't, you. And then all of a sudden she wakes up one morning and it's all gone. And she goes, I don't know what that was. Maybe I was a bit stressed at work. Maybe, my kids were playing up or something. And then it comes back again sometime later. And it's sort of this fluctuation pattern also because the brain hormones are fluctuating. So there's a lot we need to understand about mental health and the brain, but menopause really does affect the brain. And see, this is the problem. The figures are not brilliant because it depends what you define as depression. Yes, we know about major depression where there's tearfulness, sadness, can't get out of bed, can't do anything type of depression. That is major depression experienced by men, younger women, older women. But this is a different quality. This is the brain fog, the anxiety, there's tiredness, there's sleep deprivation, there's weight gain, and there's the rage, and there's a sense sometimes of paranoia about, oh, they're all talking about me at work. They think I'm an old dog who can't learn new tricks, that kind of paranoia. And a very plummeting self-esteem. I'm big, I'm fat, I'm ugly, all the negative self-talk that goes on as well. So this is a different quality. So that's why it's hard to get the exact figures as to how many women, what percentage of women go through this. But if you read the big surveys that are done, the figures are actually somewhere between 20% of all menopausal women and 60% of all menopausal women. Now, if you took either end of that, they're not small numbers. So it is an issue. And if you start the conversation amongst midlife women, you will find that many people say things like, I don't know what's wrong with me. And all of this is going on in the brain well before the hot flushes. The hot flushes everyone can recognise, oh, yeah, that's menopause. That is happening at about 50, 51. So there's about 5 to 6 years or more of other stuff going on beforehand that can be difficult to recognise as menopause.
Yeah, I mean, I think so many of these women are sort of putting these experiences that they're having down to other factors like having teenage children or ageing parents or other things like that, right?
Absolutely. And, depression is multifactorial, or mental health. Any mental health issues are multifactorial. We're not saying that's the case. That's not the case. Of course it is. Women have complicated lives, especially at midlife. They are the absolute peanut butter in the sandwich. There's the younger generation and the older generation, and they're often senior in the workplace. So then you've got all the workplace stuff going on as well. So there's no doubt there's a complexity, but it's really important when you're a clinician or, if you're the woman herself, to think about, and this is what I hear in my clinic, I have had all these complexities to look after and manage for the last 5, 6, 10 years. And I've coped because I've worked out strategies for how I deal with the crappy boss at work or whatever. And all of a sudden, there's this sort of like tipping point at which she just suddenly cannot cope. And that's what we look for, because that aha kind of tipping point, the difference between juggling all the stuff that she normally juggles and then all the balls just dropping, is probably this hormone X factor that suddenly hit her in the brain first.
Yeah.
And the fluctuations are quite massive. The other clues that we look for in who is susceptible, who's more sensitive in the brain, are women who've had premenstrual depression. There's a group of women who actually, and that's quite a big group, when in their younger years, they experience depression every cycle. Somewhere in the cycle, often premenstrually, and it's quite a sudden onset and a sudden offset. So that is kind of, you can say that's a hormonal depression, and so it's not surprising that when she gets to the bigger fluctuations of menopause, this is the woman who's going to struggle. Women with postnatal depression or perinatal depression, because again, look, the hormone shifts in pregnancy, my goodness, they're just enormous.
Absolutely.
And yet we've sort of blithely said, oh, no, it doesn't affect her brain. It's all because she's about to become a mother and change of lifestyle. And yeah, that's all true. But the big X factor here is huge changes in the brain. So if the woman has postnatal depression, then that's another clue. So it's sort of, adding up that this is a woman who is sensitive to hormonal fluctuations. And the other group that we also think is, are more sensitive to hormone fluctuations are women who've had early life trauma, emotional, physical, or sexual traumas early in life and then late in adolescence as well, because that trauma changes the brain sensitivity to the gonadal hormones. So it's really an important thing that we understand that menopause is a whole mind, body, brain experience. It is not just hot flushes. It is not just stopping periods. That's the end of menopause by definition is the one day when the woman's period stops, right?
Yeah.
But there's so much to this. Not trying to scare people, not trying to make out that women are kind of, pathetic creatures at the whims and mercies of their hormones, not at all. What we're trying to do is to say, look, we have amazing women, in our world, and it's half the population, and we don't want any woman to be left behind because of a particular mental health condition caused by the hormone flux, because we can treat the hormone flux. There are things on the market. There is hormone therapies that have been there for a while and have got better and better and safer. So that's what we're on about, not medicalising menopause. If you don't have a problem with menopause, good on you. Just keep doing your thing.
Yeah.
But if you are struggling, then help is available.
We'll be right back after this.
Perimenopause can actually start in your 40s. Declining estrogen production during perimenopause brings on changes to menstrual cycles and often the onset of hot flushes, night sweats, mood swings, and sexual problems. Promensal Peri is specifically designed for perimenopausal women and can help relieve these common menopausal symptoms. Promensal Peri is available at leading pharmacies across Australia and offers a cost-effective treatment at under $1 a day. When things start to change, try Promensal Peri. Always read the label and follow the directions for use.
Okay, we're back. Yeah, obviously antidepressants have long been sort of commonly prescribed for women experiencing symptoms of depression and anxiety at this time of their lives. Can you explain why these are basically ineffective for women who have menopause-related depression?
Well, as one of my patients said, isn't it bleeding obvious? If it's a hormone problem that's caused the depression, why wouldn't you use a hormone treatment? This is, I couldn't say it any more bluntly.
Yeah.
She was dead. So antidepressants do impact brain chemistry. That's how they work. They usually work through the serotonin system or dopamine system. I sometimes think, okay, estrogen is also going to have that effect, but it has so many other effects. So it's not that antidepressants won't improve the depression. They will, but just a smidge. It takes a lot to shift the dial, and it will have side effects as well. Antidepressants create weight gain a lot of the time. They have all these other side effects, and it's really hard to stop taking SSRIs or SNRIs. Their withdrawal symptoms can be horrendous. So sometimes it feels like, if you want to drive from Sydney to Melbourne, you can go down all the little back streets and you'll eventually get there tired, exhausted after a very long time. And that's what antidepressant therapy in menopause depression is like. Whereas why don't you just get on a plane and fly from Sydney to Melbourne quickly, because that's what the menopause hormone therapy is like, and you'll be there refreshed and ready to take on the next challenge.
So basically menopause hormone therapy is pretty damn good at treating.
Yes, but within that, we talk about menopause hormone therapy as if it's one thing. It's not. There's different types. And there is an art to matching the right sort of hormone therapy with the individual. Okay, so again, this is not a straight set and forget formula. The clinician and the woman have to be in good collaborative pathways here together and be prepared to try a bit of this and then try a bit of that, but all the time keeping her health parameters completely monitored, so that she must have pap smear regularly, must have breast screening regularly, must have blood pressure checks, know her cholesterol and all that. That's good health practice for all of our women. And, that's just a given. Yeah. So that's important to factor in there as well. But there's a lot of mythology about the breast cancer story. The estrogens that we have do not cause the breast cancer. That's been debunked. But we wouldn't give hormone therapy to someone who has breast cancer or who has had recent breast cancer. That's a group we're very careful about doing something else. You also take a story about who's got lots of relatives in her family who might have breast cancer, and you are aware of that. So it's sensible, good practice of medicine that we are looking for to keep her health, her physical health, good. Her mental health is a collaborative approach. So you do need to try the different sorts of estrogen and progestins that are available. Some are more depressive than others. So it's important that if the woman tries a particular combo and she goes back to a doctor and says, I feel worse, she's not making it up.
Yeah.
She needs to be believed. She needs to be empowered to be the one that is conducting her own clinical trial, as it were. And, there is a need to chop and change until you get the right type and the right dose and keep her physical health checks going.
For sure. Now, you've talked a bit about how the symptoms of sort of hormonal or menopause-based depression are a bit different to traditional clinical depression, with more of the rage and those sort of factors. And you also touched on sleep deprivation. So it's interesting that there are also quite a range of physical symptoms that show up that are actually linked to this type of depression.
Menopause itself is a huge process, and it's a whole body, because when you look at where estrogen works, it's all throughout the brain and the body. So it's not surprising that there's so many different impacts. And so, not that everyone gets all the impacts, but some women get a lot more of the physical symptoms, which are things like the fibromyalgias, where they've got joint pains in the shoulder, the hip, the knees. They can get bladder problems where they're going to the toilet more frequently, especially if they've had traumatic childbirth and so on. There's different symptoms, even itchy scalps. I've had women who've thought they've had lice and they've treated themselves for lice, and it's actually because of the changes in menopause to skin and hair. It affects all sorts of systems. So there are a lot of physical symptoms. The tiredness, is a really big one as well, because many women say, I just feel bone weary and mind weary. And I've had women say, I can't even pick up a hairbrush to do my hair because I'm so tired. So there is all of that as well. So physical symptoms definitely occur, often side by side with mental health symptoms, or, that some women get more mental health symptoms and a few physical, or some women are the other way around. It varies. So this is, again, where the art of medicine comes into it, because it's not an exact science that we can do. By the way, I would also caution against doing blood tests for hormone levels. Many times the woman will go to her doctor at 45 and say, I think it might be my hormones, and they get a blood test and the blood tests come back normal. Of course, the hormones are normal. Of course they are, because she's not yet in the postmenopausal or postmenopausal phase when the actual blood test shows that she's postmenopausal. We don't have capacity to look at the levels in the brain. And the early symptoms, as I mentioned, are in the brain first. So taking a body sample from the arm or whatever isn't going to give us that picture. And the problem when that happens at 45, she thinks she's got a hormonal beginnings of menopause because she's talked to other people and she's got that tipping factor, of not being able to suddenly cope and so on. She gets told, no, your bloods are normal, here's your antidepressant, or here's your counselling. Must be that, you're struggling, et cetera, and then she can go off down the wrong track for many years, unfortunately. It's common.
Yeah. So, what would be your best advice for people who do think that they are going through this experience, to advocate for getting the right treatment?
So, a couple of things. We have produced a MenOD questionnaire, which is available on our website, and it's for downloading by women and clinicians, anyone who wants to look at the symptoms and rate themselves or rate with their clinician or show the clinician what's going on. That's one thing. So we're trying to get some measures objectively of what is going on. The second thing is programs like this are vital because you're educating women in the community, because the minute you actually empower and educate women to be aware that what she's observing is absolutely vital, critical, and valid. So she needs to go to her doctor to say, look, I know that this is the beginning of menopause, and that's called perimenopause, the 8 to 10 years before the periods stop. If she can say, I am in perimenopause, let's try a hormone therapy, that is really critical to then get on the right path. So educating women, we are also educating health practitioners, but, we've got to educate the two groups together. So because this is a nice collaborative dance that should go on to let the woman get the best quality of life for herself. We do need clinical trials, and for that we need the research funding to do clinical trials. And you would be maybe shocked to learn that there are not clinical trials that directly compare hormone therapy with antidepressant therapy. I mean, we can see this in the clinic as to what's working and what's not working, but it needs to be absolutely, objective evidence so that then it can be incorporated in guidelines of how to manage menopausal mental health issues. That's not in the guidelines.
Yeah.
And so that doesn't help the clinicians because they don't have the evidence base to go, oh, look, this is probably what I should do next. So we rely on the women to speak up. And, again, you talk to each other because there's often, a whole cohort. You usually hang around with people your own age. And, again, we know that this is great for women to be empowered, understand from maybe your mums or your aunts or, the older generation, what happened for them, because that's often a clue as to what age that person went through menopause or what sort of experience they had. But this is great to get the conversation going.
Absolutely. Because I think for some women, it, as you say, it can really hit out of the blue. I mean, obviously for some women, they have had the postnatal or premenstrual syndrome, that kind of thing. But for some, they've never had any kind of mental health issues, and it can just suddenly smack them across the head, and they just, have no idea what is happening to them, right?
Absolutely. And this is we have those two groups. We have the relapse group who've had a depression before and it's been nicely managed, and all of a sudden, bang, she goes down again. But we also have the group who have never had anything and whose lives are really supportive, everything's been nice and easy. And then bang, suddenly at about 48 or something, she develops depression out of the blue with rage and everything else. And both groups, we lose them from the workforce. Mm-hmm. We commonly have this problem, and particularly, we work with different workforces. Nursing workforce is a big one where there's quite a significant loss of the midlife women who are often those seniors. There's managers in workplaces. There are senior nurses, senior doctors, and so on, senior business women. And also, I do commonly say, look, if we're worried about adolescent mental health, if we helped their mums to regain their own mental health and then take charge of boundary setting for the adolescent and being in charge, I think we'd also go a long way. And then, of course, there's the care of the elderly as well. So, midlife women are critical and vital for our whole communities, and we can't afford to leave any woman behind.
For sure. Well, going back to that, now we know that there's some women for whom, MHT is not suitable, as we said, people with breast cancer risks or who have gone through it. What treatments are available for those women?
So there are all sorts of different things that are being looked at the moment, but it's, again, the first point is making the diagnosis. What is the problem here? Is it menopausal depression? Because that will then lead you to which way are you going. Now, if a woman has if she has a history of breast cancer or if she has breast cancer at the moment, then you would go down other probably antidepressant pathways. But you could also look at some of the newer forms of treatment that are being developed, which are working on the protein peptide pathways in the brain. So there are new things coming out. But the problem is not the treatment and the availabilities of treatments, it's making the diagnosis in the first place and recognising what's going on. So, again, what we need is the evidence base to be able to give that as a guideline to clinicians to go, you can go this way or you can go this way or you can go this way, depending on what your individual patient wants and what is her physical health going to permit. But we haven't got that, and we haven't got the objective tests, like a peripheral blood sample test to look for just hormone levels is not useful. And we haven't got a test to actually measure what's going on in the brain. So that's another area of research that's missing. So, I get frustrated with the fact that if only we can pick it up that this is what the issue is, we can then get there with the treatment options.
Yeah, I mean, how far away do you think we are from getting the research to get to get those tests done and get that objective
testing? Yeah, the objective testing biomarkers, like developing those tests, is further away. The clinical trials is just all about money. It's not know-how. We have the know-how. Other groups have the know-how. It's not like it's a big, how are we going to do this? That's not the issue. It's funding for that sort of research. So that is an issue. I think we might be getting closer, but maybe I've just got my Pollyanna glasses on. I'm not sure. The biomarker stuff needs more input. But, contrast this to, remember the beginning of the COVID pandemic, people were saying, we'll never get a vaccine because it's too hard, it's an mRNA virus, blah, blah, blah. 6 months later, we had vaccine because so much effort went into development. So, why is middle-aged women's mental health not a priority? It's the thing. It is actually the thing that takes women out of the workforce. Which costs our nation and other nations billions of dollars in revenue. It takes women out of parenting effectively, which then means the next generation can have mental health problems. It takes women out of caring for elderly individuals, and that is another disaster there. So, and then there's all the personal distress about loss of relationship and all of the carnage that goes on when a previously happy relationship goes south because neither person is aware of what's going on. Why did she suddenly become this person I don't recognize?
And as other people have said, that can even lead to homelessness for many women as well.
Absolutely. So I think if we could make women's mental health, particularly midlife women's mental health, a priority, then we can move mountains. But at the moment, it's not really top of the radar. It's getting better, definitely getting better, but it's not quite there.
Well, let's all just keep talking about it more and just raise the volume and see what we can do.
Absolutely.
Well, unfortunately, that's all we have time for today, but thank you so much for your time, Professor Kulkarni. Your information was invaluable. Really appreciate it.
It's a great pleasure. And as you said, let's keep the conversation going.
Absolutely. And listeners, thank you for joining us as well. If you liked this episode, we'd love you to rate, review and subscribe. That was our final episode for Season 10 of Thriving in Menopause, but we sincerely hope you join us when we return later in the year. Meanwhile, for more information about living your best life at midlife, pick up a copy of Prevention magazine. I'm Zoe Mernier. See you next season.